Sarah Archer is an LMFT who has been working with adolescents, teens, and their families for over 15 years as a behavioral coach, individual, and family therapist. Transitioning from Rady's Children's Hospital, Sarah has served as the program manager to the UCSD Adolescent Eating Disorder Program for over 10 years. While in addition to providing clinical services, she managed all program admissions, served as the San Diego Unified School District Liaison, trained and supervised staff in evidence-based practices, and served as lead of adolescent athletic programming. Welcome, Sarah.
Hi.
Thank you so much for joining us today.
Thank you. I appreciate you having me here.
Yeah, we're excited to dive deep into this. Yeah. I think a good place to start would be to give an overview of what an eating disorder is. What are the different types of eating disorders to kind of educate the listeners on that?
Eating disorders. Yeah. So eating disorders are very layered, complex, can be confusing. I think it's evolved over the years for people to understand what they may or may not look like. I think there's a lot of myths about eating disorders, that you have to look like you have one, that it's only females, only certain ethnicities, socioeconomic status. So there's a lot of myths about them. In terms of who gets them, it's a non-discriminatory disorder. It affects everybody, regardless of race, ethnicity, religion, sexuality, gender. It impacts a variety of people. I would see patients as young, God, I think the youngest I ever knew that was admitted was like 6 or 7. And I think you'd see it to people that are still struggling in their 70s, 80s. So it definitely crosses all ages. I think that eating disorders, you're going to see a variety of different diagnostic presentations. You're going to see anorexia, bulimia, binge eating disorder. I don't know if you guys have ever heard of ARFID, but it stands for avoidant restrictive food intake disorder. And really what that means is kind of in general terms, like picky eating to the extreme where it's impacting your nutrition. And it usually involves like sensitivity to volume, like low volume intolerance. They may have had a choking incident. They high levels of disgust. So they avoid food, fear of vomiting. They avoid food not because of body shape and size, because of how they feel about food. And then you also have this whole other category, OSFED, which is pretty much people that may not meet all the criteria for anorexia, bulimia, binge eating, ARFID. And you're seeing a lot more fluidity within diagnostic presentation, and which is why I think it can be very confusing, because not everyone presents as this like textbook click, 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 click presentation. So we see here, so I left UCSD in November of 2022 and opened Align Treatment Center, which is a residential, and we are seeing a wide variety of diagnoses that kind of match every single one of those presentations I just spoke about.
So are eating disorders genetic? Are they something that is environmental that they've picked up, or is it a combination of both?
Yeah, I mean, really what we are seeing, so at UCSD, where I previously worked, they did a lot of brain imaging studies. And really what they looked at is there are iterations in the brain, especially they were studying anorexia. So there's genetic vulnerability. And then oftentimes you're going to see this for anorexia specifically, a temperamental characteristic. Like with anorexia, you see a lot of anxiety, perfectionistic, rigidity, high achieving, and then maybe a stressor, maybe not. So really kind of the way to look at it is there's, everybody has genetic vulnerability to something, right? Depression, substance abuse, blue eyes, right? So we all have our genetic vulnerability or predisposition. And then so there's like genetics, neurobiology, and again, maybe a stressor, maybe not, but there's been a lot of research really looking at how temperament really impacts the kind of combining with the genetic vulnerability can really bring out the eating disorder. So, like I said, with anorexia, you do tend to see individuals that struggle with hypervigilance, perfectionism, sometimes the anxiety. And then with other disorders, you may see more impulsivity, dysregulation. So it's kind of like the perfect storm. And again, it's like I said, the presentation's so unique and diverse to each patient. Sometimes there's trauma, sometimes there's not. Sometimes there's a stressor, sometimes there's not. I mean, you could argue, I will say there was an explosion in 2020, obviously with COVID. Oh, yeah. And all the data, I've heard people say there was like a 200% increase in admission rates through and again, it's hard to track, right, all the specific data on mental health, but I think that the pandemic really did a number on children and adolescents and adults, right? But I just saw this increase in anxiety and therefore a lot of, maladaptive behaviors to try to regulate that. So I think the best way for really to think about eating disorders, lots of people go on, diets. Not everybody develops an eating disorder. Lots of people go into a bar. Not everybody develops substance abuse. So it's like you have to have some genetic vulnerability. The neurobiological component is really interesting. There's a lot of new research really looking at how people with anorexia specifically are more sensitive to risk than reward. And they tend to think of food as dangerous. So for them, they're more focused on how to avoid that feeling of anxiety. And so for people with anorexia, when they don't eat, they actually feel calm, which is, it's almost like, oh, right. So, and there's a lot, and again, I'm not a neuro scientist, but there's this really interesting new treatment called TBTS, temperament-based treatment, that's really exploring how to more effectively tailor interventions to match their brain and what they need. Yes. Yeah. So it's really, it's really cool. Kind of, you're seeing this new evidence-based treatment. They continue to evolve because eating disorder prognosis, it's the second most fatal mental health diagnosis, second to opioid addiction. And
no kidding. I never knew that.
Yeah. Second most. Yeah. And it's this wild diagnosis that, prognosis rates haven't historically been great, especially for adults. But I think, again, I am not a researcher, but I love researchers because I want them to tell me what evidence-based treatment to use because it's a tough diagnosis to see often long-term recovery rates. But the good news is, we're seeing more and more of these evidence-based treatments come out to really help.
Yeah. That's so interesting how there's now a link with some of the brain imaging. Yeah. And I know you said that this isn't your focus or expertise, but do you know, in terms of those genetic vulnerabilities that they have identified, are those very particular to an individual with an eating disorder, or do those vulnerabilities overlap with someone, say, who has anxiety or another mental health condition? Does that make sense? When I was asking, is it specifically like a marker for eating disorder at a genetic level, or is it common with other things?
Yeah, I mean, I think that, and hopefully I answer this right. Again, I think what they're really looking is at the frontal lobe and how there's iterations regarding risk and reward, like I was talking about.
Okay.
So we will get patients that are anxious only in the context of eating. And then we'll also get a whole group of patients that are anxious in the context of eating, but also have OCD, also have social anxiety, also have generalized anxiety. I think I'm seeing more and more of those patients. I don't know the data on, the difference, but I do think the comorbidity between eating disorders and anxiety is extremely connected. Did that answer that in any way?
Yeah, it did.
Yeah.
And also what you're saying now adds to that, because now I'm understanding like the feeling or emotion comes first, and then the behavior of the eating or not eating that becomes disordered. Is that right?
Yeah. Think of the way I kind of think of it is like, there's a level of distress that the behaviors are trying to mitigate, right?
Yeah.
So it's like it might be restricting, binging, purging, self-harm, whatever it is, but the eating disorder behaviors are like a desperate attempt for the individual to regulate discomfort.
It's exactly what I was thinking about, like with OCD. They've got their compulsions so it's kind of this unhealthy way of coping with anxiety or the uncomfortableness. And in this case, it's that control over food that is helping them calm their uncomfortableness, for lack of a better term.
Yeah. I mean, there's definitely that component of it where, I've had patients say by restricting what they eat, they feel calm, they feel confident, they feel, again, I think is control a part of it? Yeah. And is it everything? No. Right. I think that would be my biggest takeaway for you guys is that, like, right when you think you have it, like, oh, it must be, it's like, no, there's another patient but I will say it's restricting is the core behavior that leads to everything. So like restricting with anorexia is a way, it's intense fear of weight gain, severe restriction. With ARFID, restriction is a way to avoid food because it makes you feel nauseous or disgusted or fearful. With bulimia, restriction leads to later, binge purge. And then with, it kind of goes on and on and on. So it's really for them this almost knee-jerk reaction when they feel distressed, where if we think of all of us, we all do something probably maladaptive or unhealthy. Right. We may grab a glass of wine, we may yell, we may shop, we all do something. I think the thing that's why this disease is so scary is that when people have like acute restriction, purging, avoidance of food, they have medical complications. So what happens is a lot of people end up at, at different hospitals for medical stabilization because their potassium levels are off due to purging. They have low heart rate. They have orthostatic vitals. They're severely underweight. Because those behaviors are really dangerous. That's why it's so deadly, because those behaviors impact the body so much.
Yeah. And what is it doing to their brain?
Oh, their brain. I mean, brains, I think they say now, is it 27, 26? Like your brain
keeps on rate.
Yeah. It's going to be like 50 soon. Yeah. My brain
work in progress.
Exactly. I think it definitely, if you are depriving your body of adequate nutrition and energy, it's going to you're not going to have full potential of brain development. Chronic purging, like all of that, yes, will impact your brain. And that is something that, because again, as a clinician, I'm always trying to figure out, like, how do I motivate this patient? So if I have a patient that is like, wants to be a doctor, wants to go to a good college, I'll say, again, you're depriving your brain of its full potential. They need reasons why they should do something that feels so bad to them. Focusing on the brain, the heart, all the organs, it impacts your hair, your nails, your skin, your teeth, your energy levels, it impacts so much of your body. So for adolescents and families, kind of explaining to them the serious impact can sometimes be like both alarming and a little bit like humbling to be like, oh, wow, like I didn't realize how bad this was.
That's interesting that you said, how do you motivate one of your kids or someone that you're working with? Because I guess like anything else, to affect positive change, especially in your own health, you really got to want it. You have to be, you have to own it. You have to have buy-in. So how hard is that?
Yeah, that actually can go into kind of what, so how I mentioned earlier, like evidence-based treatments. I love scientists and researchers because they're the ones really doing the studies to find out what has positive outcome. So the only evidence-based treatment for children and adolescents with anorexia is family-based treatment. Because they're so young, their brain's not fully developed, and because they're under the influence of their eating disorder, children and adolescents often have no motivation to recover. So family-based treatment is you have to bring in a parent to support them to recover, because they're just not in a place to be making decisions. So, and part of that is because they might be underweight and brain starved. Part of that is because they're engaging in dangerous behaviors. They're young, they're ignorant, they're teenagers. So they're children, right? So it's like thinking like you wouldn't let your child decide to take a life-saving medication or not that they needed. If they said no, you wouldn't be like, oh, okay, that's fine. But for eating, it's the same way. So at Align, where the program I run right now, it's a family-based residential where we are educating parents on how to support their child in the recovery, because the patients don't have that motivation. The idea is that over time, you work with them on, we call it like building a life worth recovering for. And that can develop, like we do that while they're here also. They just need their parents like in conjunction. So we're talking about like, is it sports? Is it school? Is it relationships? Is it travel? What is going to help motivate you to do this? And what I have seen is there's kind of this like, this journey for them where in the beginning, a lot of them are doing it just to stay out of the hospital or stay out of treatment. And then maybe they want to go back to school, or maybe they want to play soccer, and then maybe they want to go to college, then they want to stay in college, and then they want to have a job. So it can evolve over time, but it's motivation just because it's like healthy and the right thing to do is pretty low, because that intense fear of weight gain or the struggle to regulate or wanting to look a certain way is so powerful that motivation is really hard.
I would imagine as a parent that is almost a full-time job to work with your child on that, because they have to eat all day long, and there is these aversions to eating, and to try to negotiate that would be very difficult.
Yes, I think FBT is exhausting, relentless, unfair, maddening, to be honest, because again, like the idea, like the nutshell of what FBT is, it's supervising and supporting your child with their meals, preventing them from engaging in harmful behaviors. And you have to do that by supervision, using rewards and contingencies, time. And it's extremely difficult, because when you're trying to get your child to do anything, right? Brush their teeth, eat their vegetables, go to school, do something difficult, you're going to see opposition. You're going to see tantrums. You're going to see, and for this, it is so uncomfortable to eat, stop purging, stop engaging in certain behaviors, that you're seeing kids that maybe have always done the right thing. Maybe not. Maybe they've struggled historically, but a lot of times you're seeing these kids like the meltdowns are massive. They're intense. There's threatening suicide. There's running out of the house. There's physical aggression towards self and others. So yeah, it's pretty intense. Traditional FBT is outpatient, where you meet with a therapist once a week, and you're really looking at how they're doing with their eating disorder goals. And I think what's happened over time is that the acuity of symptoms have increased, and the ability for parents to do this just on their own, it's really challenging. So you see programs come in like PHPs, partial hospitalizations, that are 10 hours a day, IOPs, a lot of virtual programs. And then I'm running the residential, where the patients stay with us for a period of time while we're educating the parents to then be able to do it more effectively when the kid gets home. But yeah, I mean, a lot of the parents, we have a support group. We teach skills. We have about 8 hours a week of parent groups. And on Mondays and Fridays, we just have a process group for parents to cry, to yell, to vent, because it's so, it's scary. And then I think parents always tell me too, it's like, and I have a job, and I have and my parents' health is declining. Mm-hmm. So it's like that sandwich. Have you heard like the term sandwich? Mm-hmm. Like you're taking care of your aging parents, your teenagers, and then let's say you have 1 to 2 or 3 kids, then this kid requires so much time. And so it's really difficult. I think a lot of parents feel really defeated that their child needs a higher level of care. But the way I really look at it is that they're doing their child such like a loving gesture by putting them in treatment, because I think time is so important. I think waiting too long can really impact their prognosis. So I think sometimes parents have had to make really tough decisions. Like, we've had parents from throughout the country put their child in our treatment center, and they're just like, I can't believe it came to this.
I can imagine.
Right. Mm-hmm. But at the end of the day, I think by getting them the treatment they need and then stepping them down to lower levels, it really can impact recovery rates, which is great.
Mm-hmm. So my daughter had a friend in high school who had an eating disorder, and she had to quit school for a while because it was so intense. But when she came back, they actually paired her up with my daughter. They went to they go to Disney for their senior trip. Oh, yeah. And they hooked her up with my daughter so that my daughter would attend every meal with her, and that she made sure that they weren't just getting snacks, that they were actually sitting down.
Your daughter was her?
My daughter was during this time, so that I know. But I thought it was I know, but I think she was further down, but I think they wanted to make sure that she could still experience life, but had the support to make sure that she was eating and such. And so, I mean, I found it interesting. Is that, by your expression, that is not normal? I was going to ask if it was normal.
I'd ask your daughter, like, what was that like for her to feel responsible for someone else's? That says a lot about what they thought about your daughter, that she was given that task. That's interesting, because that comes up sometimes with like siblings. Like, do I have the siblings? Do I have the friends at school? I think often with school's really hard to step back into, I will say, because it's pretty easy to engage in behaviors at school. You can throw out your sandwich, you can go to the bathroom. So what often happens is when patients are about ready to go back to school, we might say to the parents, like, can you come to school, eat with them? Which is hard, right? Often a dual income household, that's a really tough thing to ask. Or can the nurse eat with them? Or can they, leave class 10 minutes early before lunch, eat? I think that it takes a village. I think that's amazing that your daughter supported her in that. And I think that can put unnecessary stress on peers and siblings to say, like, you're responsible for this kid to eat. And it kind of can change the dynamic. Like, who wants their friend to be like their mother or their, right? Like, it's kind of like, so I think, every now and then we've had like older siblings, like if you have a 14-year-old and like a 24-year-old, like sometimes we'll have an older sibling say like, okay, can you, support your family in this, or a teacher or a nurse, the school therapist, the counselor. And every now and then friends, I think sometimes friends won't tell you the truth, right? If a mom was like, did they eat? And it's like, sure. But that's, hey, but again, it's sometimes people have to get creative, because there will be schools that say, we're not helping with that. So I think that sometimes you have to get creative.
I think it was more of that she was down the road, that my daughter helped ease her anxiety, and she had confided. And so they were like, okay, it wasn't that my daughter had to go tell her that she had to eat, but that she was going to be there, for lack of a better term, holding her hand or holding her shoulder while she was eating, just as a support network, basically.
Yeah. And I do think, when the patients, we talk about this a lot of the patients experience a lot of shame and guilt about their eating disorder. So it's like, who do you tell? Some of the and this is the same with parents. Parents will say like,
oh, sure,
do I keep this like secret, or do I tell the grandparents, my best friends? I do think the benefit of what you just said is, I think, and I've had patients do so. I've had one patient give a school presentation on their eating disorder.
Wow.
I've had patients not tell anybody. I've had patients tell a couple. I do think patients need to tell peers. I think it's helpful, like you said, to have somebody that can distract you, that knows like, okay, eating for my friend is hard. So I know they love Friends. So every lunch we're going to watch like a Friends episode on my phone, or I know they get really dysregulated after a meal. So like, we're going to go gossip about all the people we have crushes on or whatever. Like, I think, I do think in that way, friends and siblings can be great distractions, great ways to support them in achieving their goals. So no, I think that angle is definitely helpful.
Do you remember when we were younger, Emmy? And Sarah, you're younger than we are, so you may have already been past this, but
maybe not. Yeah.
But when we were younger, like if you saw somebody that you suspected had an eating disorder, you thought they were doing it for looks. I mean, like that they were just, and it's so not that, and they can't control it, and it takes a lot of work to get past that. I mean, I think we've come a long way.
Yeah. And it is. I mean, I think there is a level of focus on body shape and size, right? Like there's definitely like, can you imagine growing up in 2024 as a teenager with access?
No, I couldn't do it. We talk about that all the time.
No. And I do. And like, not only social media, but the stressors. So sometimes I do wonder, like when we have parent group, I'm like, I wonder if these kids were like raised in the 80s, like, would they have as many struggles? Like I do think when you talk about what is the additional stressor, this generation, I mean, they experience the amount of information they have coming at them at every second about everything from like, what's going on in Gaza, what's going on with the election. Right. Oh, by the way, a glacier is melting and the environmental, so I think for them, there's this level of like chaos. And then on top of that, I think the focus on body shape and size is still very prevalent. But again, like you're exactly right, Andrea, like not all eating disorders are really like simply just focused on that. They're focused, there's a whole other reasons why it exists. So I think that, a lot of these, a lot of the patients I work with almost feel like how do you survive in a world where you don't really ever feel secure, or like safe, gun violence. Like I've had patients with anxiety disorders, like 15 years ago, I'd be like, all right, let's check the facts. Like, is something bad going to happen? And back then I could be like, now I'm like, it's harder to challenge cognitive distortions when you're like, maybe they're not distorted. So I do think it's a really hard time. I also think another interesting thing that I've seen, you'll hear us talk a lot about distress tolerance. So
distress
tolerance skills. So along with family-based treatment, which is pretty much empowering and educating parents how to help their child recover, a lot of what we're teaching our patients themselves is DBT, dialectical behavioral therapy. And one section of those skills is called distress tolerance. So it's like, how do you regulate intense emotions? I do think something I'm seeing with this generation, I hate to sound like, is that they overall have such low distress tolerance. And I think some of that is because they don't really need to have any. Because like I was thinking about growing up, like I remember like I'm from Massachusetts, and I remember like standing in line at a CVS, and like you wouldn't look through your phone, you just stood in line. You stood there. Like we had to wait for things. We had to look through Encyclopedia Britannicas. We remember those? Like
we had
to print out Google Map direct, like not or
MapQuest
directions. So I do think like, they have such information so easily readable, which on one hand, it's like, oh, wow, like their brains are just such capable, but they have such low distress tolerance so that it's almost like they can't have any uncertainty, and a lot of them need like immediate change or support or guidance. So a big part of treatment is also teaching them better distress tolerance skills. So for them, their distress tolerance skill is restrict, binge, purge, avoid, overexercise. Like that's how they immediately cope. And so we're coming and saying, no. Hold ice, splash water on your face, watch a video, hold something that is a texture you really like, do some paced breathing, do muscle relaxation. So we're trying to also be like, hey, how can you improve your ability to manage really intense emotions?
I love that. I've never heard that phrase before, distress tolerance. That hit such a huge nail on the head for me. And then what you're saying as some of the healing modalities, go-to tools are mindfulness tools.
Yeah.
One and the same.
Yeah.
So we're all coming back to the same thing time and time again, Andrea.
I know.
DBT. So if you look it up, DBT, and it sounds dialectical behavioral therapy, really it's all about like acceptance and change. It's kind of the idea as a clinician, you're working with your patients on like validating their feelings and using skills to change their behavior. It's kind of like, of course you feel that way, and what are you going to do about it? So it's broken into 4 sections. It's mindfulness practice, distress tolerance, emotion regulation, and interpersonal effectiveness. So it's really like how to be, in the present moment, how to regulate stress, how to manage your daily emotions, and how to be effective with other people, which is pretty much like life skills, right? Like a lot of these patients that we work with, like, these are things their siblings need, their parents need, everybody needs DBT skills. And I think DBT was originally designed by Dr. Marsha Linehan for individuals that struggle with more like borderline personality traits, but they've really been adapted over the years, or just utilized for adolescents that struggle with maladaptive behaviors. And we do see a lot of patients that, along with their eating disorder, struggle with suicidality, self-harm, and these kind of skills really also help manage those.
What are some of the thought patterns or underlying beliefs that you tend to see leading right up to the start of that eating disorder?
Good question. I have heard everything from like, I'm not good enough. I mean, your classic like core belief, right? Like, I'm not good enough. I'm worthless. I'm not lovable. I'm disgusting. I'm fat, which is, I think, two things on this. I think what I see often is you'll see adolescents. I think peer relationships are so important to adolescents, wanting to fit in and not be an outlier. I think I don't fit in. People don't like me. You'll see a lot of that. I also think you're going to see another big group of kids. I can't tell you how many times a patient has gone for a wellness visit with their primary care doctor and told to lose weight. All very frequently, and I can get more into that, but I think for a lot of the patients, they feel like, yeah, I am disgusting, I am fat, I don't think people like me. And I think for a lot of the patients, that can lead to a lot of behaviors.
You know, you struck a chord when you said the doctor. When my daughter was two, she was always tall. And I mean, and you know, kids gain weight before they shoot up, right?
Yeah.
When she was 2, the doctor said they were concerned about her BMI and that we needed to watch. And I said, I don't ever want to talk about this in front of her again.
Yeah.
And the next visit, they made me come back in like 3 months, or they didn't make me, but I went back in 3 months, 6 months, whatever it was. Maybe it was 6 weeks. It doesn't matter. And she was like, fine. And I thought, why are we even having this conversation?
Why are we obsessed? Yeah. I mean, this is actually a really important topic. So BMIs are a pretty archaic way of measuring health. They're still utilized all the time, even in like, you know, we use them sometimes for insurance purposes, or they are helpful for some, you could argue, dietary things occasionally. But in terms of it being the perfect measurement of health, it's not. So what they do is, I think of, you know, yes, there is an obesity epidemic. We know that. But I think part of the reason there's an obesity epidemic is because of diet culture, to be honest. It kind of, if you really look at when the obesity problems kind of came into the United States, it was actually linked up when diet culture came in.
Interesting.
Oh, wow. That is interesting.
Yeah, it's kind of, and again, I am not a dietitian, so hopefully my RDs will do me proud. Really what they looked is that like, we all have genetics, right? Whether we like it or not, we have our own typical, like our own set points based on our parents. It is what it is, right? And I think when you're constantly trying to change your natural genetics by restricting, usually what happens is you restrict and then you lose weight, right? People lose weight on diets, and what happens is then they gain the weight back plus 2 more pounds. And then they're kind of constantly trying to, so oftentimes people's natural set points keep going up. So I think what happened is doctors with the obesity problem got really focused on like 50th percent. Everybody has to be at the 50th percent. Well, not everybody is, and not everybody should be. So I've gotten a lot of patients, especially Hispanic females, who go to their doctor, and let's say they've always been on the 75th, 85th. That's just where their organs work the best, their brain works. That's where they've always tracked. They're not binging. That's just their body, their fabulous, beautiful body. And a doctor says, you need to lose weight. You need to get to the 50th. And then they end up in the hospital because for them, being that low weight gives them a low heart rate. So we're seeing a lot of that. And again, well-intentioned doctors, but it boggles my mind sometimes how in 2024, doctors don't have the education they need about weight, adolescence, why not everybody needs to be at the 50th, why we're weighing people at the doctor's office when they have a cold. Like it's this obsession with weight. There is data, I don't know the exact numbers, but there is data that a sedentary lifestyle is more damaging than your weight.
Right.
So that, you should be moving your body in a joyful, fun, competitive, whatever it is way. That is definitely a healthy lifestyle, not what you weigh. And everybody too, they looked at like bone mass, muscle, like some kids that don't even appear that they weigh a lot do. And then and it's because your frame, it's not just like everything impacts your actual number on a scale. But being told you need to lose weight can really impact a kiddo, and especially from a doctor. Like I can argue, but a lot of times the patient's like, "But a doctor told me," and then it's like, how do I convince them a doctor is wrong? So something we're going to try to do when we have time is really put together a series for primary care doctors, really educating them about eating disorders and how vulnerable it is to talk about weight with children. And again, I think, and again, they're doctors aren't in the business to hurt children. So this is all, but I think they're overworked and don't have the time to get probably the education and training they need, because they're seeing, 50 kids a day. So it's really tricky. So I think our goal is to figure out a easy way for them to have access to this kind of information so that they don't give wrong information to really vulnerable kids.
Gosh, really to be a pediatrician these days, you're not just slapping Band-Aids on anything. There is you're dealing with so many different components. And how do you keep up to date with all of that information?
No, and we have at our clinic, we have a psychiatrist and a pediatrician, and he and I were talking about that. Like he's just like the mental health combined with the medical. And not every doctor has the ability to get access to information. So it's kind of, we're trying to figure out like, okay, it's our job to educate them. And then how do you do it in a way that's not going to be like annoying or time consuming? Because there's only so much you can do.
Yeah. I can't stop smiling ever since you said something. I just have to go back to it. You said, move your body in a joyful way. And I've never heard anyone say that, but so many people would say, move your body to exercise and lose weight, or move your body in an athletic way with a kind of a purpose like that. But move your body in a joyful way, just like, that just made me smile. And if we encouraged our kids, what would be the result? Yeah. What would we see? Right? Yeah. That's so special that you said that.
Oh, thank you. Yeah. And it's something we talk about a lot. There is some data that 40% of athletes struggle with disordered eating because there's a lot of focus on weight, body shape and size.
Yes.
It's like kind of a culture. Yeah. I hear horror stories about coaches giving dietary advice like to their teammates, right? Yeah. To their players. Yeah, I think for eating disorders, especially, like exercise can be a really slippery slope because people can struggle with compulsive or compensatory movement to give themselves permission or forgiveness to eat, right? One form of purging is also exercise. So in like 10 years ago, it wasn't like 10 years ago, nobody really talked about exercise. It was kind of like, but like I said, exercise it's great. It helps with mental health. It's fun. I tell parents like their disordered exercise is a significant factor for relapse if people don't talk about it or deal with it, instead of just saying, oh, you can't exercise. Like adolescents go to PE. They're on more than half of adolescents do some kind of recreational sport. They hang out with their friends, playing football, running around the beach, whatever. So it's something that is super important. And so we have criteria of when they can return to exercise. But something that's like really important is joyful movement. Like there's too many kids I see in the gym. I don't feel like the gym was like something my generation really did, unless you were with like your team. Like I played soccer, so occasionally they'd make us like lift, but not like they do nowadays. But like I think it's common for like adolescent boys and girls to be like hanging out in the gym.
Absolutely.
Like, and I think like and again, they could argue that's joyful. I'm like, no, like go ride your bike outside, like go skateboarding, go hiking. So yeah, I think we want making movement more joyful rather than a job or rather than something you feel you have to do is so important. And I think,
interesting.
If everybody, because think about like asking yourself, like, like, why do you move your body? Is it because you feel like you have to manage your calories for the day, or is it because it makes you happy? So I've worked with a lot of teens. I worked with very long time ago. I've worked with like patients that have been like on the track team, and they say like, I'm like, does this make you happy? Some it does. They're like, I love being in nature and I love winning. And I'm like, sweet, keep doing it. But some are like, no, I've always wanted to sing. I'm like, then let's go sing. So I think if you have a child and movement seems like it's a job or a chore or something on their checkoff list, like they need to do something else. It might be a different activity. It might be art. It might be academic. Or like walking the dog can be joyful, moving your body in some way, but making it. That. Yeah, good. Yeah, it's something. I think it's important.
What is, you said disordered exercise and disordered eating. What's the relationship or difference between disordered eating and eating disorder? Are they one and the same?
Yeah. So like I think like you're going to see people that, again, you could argue, how many people do you know that eat like consistent meat? Like we look at like, think of it like we do 3 meals and 3 snacks, where it's like our patients here eat at 8:30, 10:30, 12, 2:35, and 7:30. That is very rigid. We also have a schedule we have to maintain, but kind of the idea is that like if you have consistent energy, you won't overeat, and your body will have all the energy it needs to function properly. And you're not going to end up binging and purging. You're not going to end up losing weight or being malnourished. I think in our culture, you could keto, intermittent fasting, just diet culture. I don't know a lot of people that eat consistently. There's always this like, well, I eat more on the weekends, or I punish myself for this. So I think there's like people that have subclinical traits. Like I could argue like, oh, half of my friends do, right? Or like people in society, we all kind of have this, even, there's times where I'm busy and I'm, may miss a meal, but then I'll make it up later probably because I'm starving or I'm eating at my desk. Like I don't think our culture really promotes healthy eating in general because we're all like so busy bopping around. But I think like orthorexia, that is a diagnosis that focuses on people when they're really focused on like clean eating. And maybe they haven't had significant weight loss or intense fear of gaining weight, but it's kind of like a very specific way they eat.
Yeah. So that's clean. Disordered?
Yes. Like it will. Oh. Yeah. Yes. I think I think the biggest way you could like disordered is like time and energy spent on that. I think there's a difference between like, I am very conscientious about how I eat. I enjoy foods that are fresh and I enjoy moving my body. That's great. There's no problem. I think where it gets tricky is where it's more like, you know, I won't go out to eat with my friends because I don't believe how they eat, or I exercise this many hours a day, which impacts my time with my children and my spouse and my other hobbies, or, you know, I think about food 5 to 9 hours a day. Like, I think people can eat any way they want, right? Like, I'm not here to judge how people eat. I think it becomes disordered when it becomes the sole focus of that person's daily life.
Oh, that's interesting.
And I think we have a culture where, like, remember, like, people, I feel like people are less taking pictures of their food. I feel like,
remember that?
Remember that? I was like,
oh
yeah.
Gosh.
Like, I feel like there is this like obsessionality of like exercise and what we do, what we don't do, where I think it can become a disorder and kind of that orthorexic thinking pattern when it really just takes over your day and your thoughts and impacts your time.
Mm-hmm.
And I think that's the case with a lot of disorders. Like, you might have traits of this or traits of this, but how much is it impacting your day and your time?
So you're a parent out there. What are some things that they need to be aware of in the day-to-day life of their kids for early detection of a possible eating disorder?
Great question. Yeah, I think as a parent, what to look out for is, I think, avoiding meals, starting to be very picky about how they eat. Like, a lot of patients will start off by saying, well, I decided to like cut out junk food, or I started to cut out carbs, or I started to, you know, and suddenly they're eating, like, I say, like grapes and carrots, right? It's like, we do have a philosophy, like, all food fits in moderation. And, you know, teenagers also are going to go out with their friends and eat pizza and burgers and fries and milkshakes or whatever. So I think if your child who was eating all different types of food suddenly wants to like go on a diet. Again, you can probably tell I don't like diets. Again, like, some people might say, oh, like, I want to eat certain foods or whatever. But I think you have to, like, the second you hear your kids say, I want to go on a diet or I want to cut out foods, watch that. I think if you see them weighing themselves a lot, I think if they seem anxious before, during, or after meals, I think if they kind of starts, I'm good, avoiding meals, I see a lot of patients tend to start isolating from their friends, stopping activities that used to be pleasurable. Again, I think weight loss. I think that if you're seeing your kid, again, if they're on their weight trajectory, if you see them starting to fall off their natural trajectory, that's an indicator. I think engaging in, like, being in the bathroom for a while, going to the bathroom right after meals, significant change, I'd say, in mood, irritability. Again, when you're not getting in nutrition, and if you're purging, it's going to impact their ability to regulate their emotions, their ability to focus. If they're an athlete, how is their sport performance? Are they wanting to exercise more than their team? Like, I have a lot of patients that, you know, have 2 hours of practice every day, and suddenly they're like, I didn't get enough exercise. I need to go for a run when I get home. So increase in exercise. I think a lot of those things are indicators that you could have something going on. I'm trying to think of others. I've heard so many things, you know, finding food if they're binging, finding wrappers, you know, kind of going from I don't eat anything to wanting to hide in their room. What else can I give you? Let me think of other things for you. But yeah, I think, and it's hard because I've had a lot of parents say to me, like, oh my God, like, I can't believe I didn't notice. I would say that's like the number one thing I hear a lot from parents. And I think, you know, when you live with somebody and they lose weight or they change, and just because you're with them all the time, you don't see that, where somebody else, like, after 2 months is like, oh my God, you look so different. So I think, you know, a lot of parents will beat themselves up and say, I cannot believe it got this bad. I think eating disorders are so sneaky. Your child is not sneaky, their eating disorder is. So they hide foods in their sleeves, they throw out meals, the eating disorder can really engage in a lot of behaviors. I've had patients like hide weights on them when they go get weighed in. Yeah. Wow. So it's a desperate eating disorder that's trying to kill your child at the end of the day, right? I really look at it kind of like an abusive relationship that tells your child like they have to keep it to get rid of every other thing in their life. This is the only thing that matters. So I think all of those factors, you could see any one of those play out. But I think like trust your gut. Like if you feel like your child is just being strange with, they're more depressed, they're more anxious, have them see a therapist, have them talk to somebody. I also think my personal opinion is every adolescent and teen should have a therapist, regardless of if they're showing.
I agree with that.
Right. So I think that
it's kind of a new way of looking at the buddy system.
Yeah, exactly. Like, why not be more proactive? Because there's because the anxiety and depression, I mean, that needs support, significant help, that I think having somebody they can talk to outside of the family, outside of friends they can trust is really vital. And therapists, can help guide and support your kiddo and also bring you in as a parent if necessary.
Mm-hmm.
You said something and you said it very quickly, but I want to reiterate it. You said it's not the child being sneaky, it's the eating disorder being sneaky. And I think in so many of these mental health conditions is separating the disorder from the child is so important. And it's also eye-opening, I think, when you're parenting those kids to be able to put that back on the disorder, not on the child.
I think separating any illness from a person really helps you treat them still with compassion and kindness. Right. I think a lot of people have thought of this as like, this is just a child being a pain in the butt, or this is just them, trying to be difficult. But now that we know it's brain-based, temperamental-based, the comorbidity with anxiety, it's not their fault and it's not your fault as a parent either. And so the more you separate it, like, okay, there's Jack. Okay, there's Jack as a child. He's wonderful. He's, super kind and conscientious, hardworking. And then when Jack's eating disorder, when I always say, like, when they're under the influence of the eating disorder, Jack becomes oppositional, aggressive, hypervigilant to the point of just like obsessionality and nagging. And I think it helps parents, because as I said earlier, it's such a relentless disorder. I think it gives parents a little bit of like, okay, this is not Jack. This is the eating disorder. I have to stay calm. I have to do what I need to do to get rid of the eating disorder. I think eating disorders are also really good at like playing like, well, you weren't there for me, or, if you make me eat, you're going to make me hate myself and I've never had friends. Look what you're doing to me. So I think the more you separate it, it can be helpful. On the flip side, I will tell you, sometimes patients hate that. They'll be like, it's me. Why do you, I'm not crazy.
Oh, I could see that.
Oh, they get really
they're not being validated for being them. Yeah.
Yeah. So I think it's something like we use more for parents. Like every now and then patients will name their eating disorder and say like, some patients really hate that. So again, like right when you think you have like a streamlined approach, you have to be like, okay, this doesn't work for this patient. But I do think separating the illness from your child, it kind of makes you realize like, okay, like they're not completely gone. And I do think behaviorally, like you still have to like look for the moments when your child is present and attend to that and be there. Because I can't tell. it's an exhausting illness where parents feel, I just think, completely like paralyzed by what to do. And I think, I've had parents say it's really hard. Like, I feel resentful. I feel angry at my child. I feel this. They've ruined our lives. This has been going on for 3 years. We had to refinance our house for treatment. I couldn't attend my, older siblings' graduation because they refused to get out of the car. So you hear stories like this where I think, to help parents kind of move forward, it's like, okay, you're battling the illness. Your kid is there. Your kid is wonderful. The illness is the problem.
Mm-hmm. Gosh, you said 3 years. That would be depleting. Is there a way you can quantify for people? Is there a timeline where a certain amount of time goes by and you say that you've hit that threshold of being life-threatening at that point?
Well, I could tell you for I can answer that in a couple of ways. Hospitalization. So like when it's like life-threatening is, so for people to get hospitalized, it's acute weight loss, bradycardia, which means low heart rate, usually like under, 42 heart rate, 75%, did you 75%?
It's like she fell. Andrea's down.
Andrea's down. That was amazing. I'll go back and answer that again. No, it's okay. It's totally fun. That was funny.
Andrea, stop playing with your chair.
Yeah. That was really funny. I will answer that again. So yeah, the threshold, I would say if your child is having acute restriction, like they're not eating, and especially if they're restricting fluids, that is I think I've had patients 2 or 3 days, they end up, in the hospital because it can be very quick. And I think, so acute restriction of fluids and solids, I think when they are below 75% of their ideal body weight, that's when often they're hospitalized. When their blood pressures are wonky, it's called orthostatic by, blood pressure or heart rate. So if that's the thing about this. I've had a lot of families be like, oh my God, we went to our primary care doctor and they told us we had to be hospitalized, and I was shocked. And if you are worried right now about, if you are anxious or concerned that your child has lost a considerable amount of weight, is not eating enough or drinking enough fluids, and get them assessed, because I can't tell you how many times they end up at the hospital. I think for a timeline, and again, like I said, there's different levels of care. Outpatient, IO, so it goes like once a week therapy, like that, anywhere between 3 hours a week, 3 hours a day therapy, 6 hours a day, 10 hours a day, residential, inpatient. So it's kind of this like, boop, 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 boop. I have had people that just started outpatient, get assessed, go to the hospital. So that can happen. So I'd say my biggest advice to parents listening is that get your child assessed as soon as possible if you are concerned they are engaging in behaviors. For patients that purge a lot, they can have this condition called hypokalemia, that purging consistently can impact potassium levels. And again, this is why this disorder is maddening. It doesn't happen to everybody. I've had patients not purging a lot where it happens, and patients that do where it doesn't. I don't quite understand the science, biology behind that, but make sure your child is being assessed by their primary care doctor. This illness is, unfortunately, I wish it was just like you're in, you're out, you're better. You will see occasionally patients that the parents like, okay, they get treatment, they weight restore, they supervise, they continue to do the work where they can manage it. And I've had cases where it's a 7-year battle. I've had a patient die. So it's one of those illnesses that, unfortunately, I wish I could say to parents, like, this is an easy fix. I will also say my biggest advice to parents is, I think that if anyone is telling you it's a quick fix, or any program is saying like, we guarantee your recovery, it's not a good program. So I think when you're shopping, quote unquote, for like good treatment, I think you want to look for evidence-based treatment. For children and adolescents, that's family-based treatment. I think you want to find a place that teaches them evidence-based coping skills like DBT, cognitive behavioral therapy. And you want a program that understands that this is a journey, and that your child may need to experience every level of care. I think the one concerning thing I am seeing going on right now is, I think there is like time, I think, and ease of treatment. I think it's really easy to do treatment at lower levels of care because the kids can stay in school, or you can do it from home. But I do think if your kid is sick enough that they require a higher level of care, it's best to do that, in my opinion, because I do think time and avoiding the level of care that they need can really just keep them in treatment longer. And that could be like even putting them in IOP. Like if you're like, oh, I can't, like, not every kid needs to be in residential. Absolutely not. And traditionally in FBT, residential was kind of looked at like, oh my God, you're taking them away from the family. You're doing like a parenectomy. You're blaming the family. And there's a lot of residentials out there that, unfortunately, based on their treatment model, don't really include parents. And it does kind of continue that that path. I think the reason I really wanted to start Align is because I felt that, especially after COVID, there was just such a high acuity of and severity of symptoms that families really needed treatment centers that provided that 24/7 supervision, while also at the same time teaching parents nutrition and teaching parents DBT, parent management techniques, sibling groups, couples work, family work, so that when they step down to lower levels of care, they do them more effectively. Because I do think sometimes you'll see patients that have been in treatment for 3 to 4 years, and they've missed out on developmental milestones. They've missed out on, their educational goals. So I think getting the level of treatment your kid needs is really imperative, and helping them get back to their regular life as soon as possible is also imperative. And it's like, how do you do both at the same time? It can be a dance, if that makes sense.
Yeah,
absolutely.
Yeah. Because it's also,
I feel like I could ask you a million different things. I mean, like, I could probably do a whole other episode on this. It's just,
it's really, and the other thing, last thing I was going to say is the other thing that's really interesting to me as a clinician is that, like, I think the other thing we're battling sometimes is that I think, how do I say this? I don't even know if I want you to add this, so hold on.
We can edit.
Well, I think what I'm seeing is that, again, I'm seeing a lot of children and adolescents struggle with so many different things: self-harm, eating disorder behaviors, worry, depressed mood. And I think there's all these strategies we teach parents how to, like, attend to behavior you want, ignore certain behaviors, set up rewards and contracts. Like, there's all these ways to try to manage your child's behavior. I do think, though, mental health has within their peer culture is something that is so almost reinforced, where I've had a lot of patients say to me, like, I talk to all my friends about how much I self-harm, or everyone self-harms, or if you're not depressed or anxious, you're kind of the outlier. So
my gosh,
Sarah, we've talked about this.
And we've said trendy. It's sort of trendy to have fill in the blank.
Yeah. So it's kind of like, again, because I do think the peer evaluation and peer what's the word? Peer, just the need for these children and adolescents to fit in, feel good, be a part of a group is so important. And I think, unfortunately, for parents, like, they care more what their peers think, just like we all did. Like, I didn't care what my parents thought till I was probably in my 20s. I started to be a nicer human being to them. But like, I think they care so much what their peers think. And I think there's this environment where openly talking about how much you struggle is so present that sometimes it can be hard to like shift patients out of that like treatment way of looking at everything. Like you're more than just like a sick kid.
Yes.
You are all, and your mental health is a part of you and not something you should ever be ashamed of, but it's not your only factor. So I do think that's something. So a big part of what we do is like really help them build a dynamic life worth living. I have noticed a lot of these kids that struggle with anxiety, depression, eating disorder, they're very sensitive and empathic. And they're very good at taking care of other people's distress other than them, and have a harder time. So I love these kiddos volunteering. So I think in making that like,
it's a great idea.
Yeah. So we do this thing every Saturday. There's this really cool platform called meaningfulteens.org. And they offer a lot of virtual volunteer. Like, it could be anything from like our patients every Saturday, like read to kids in Ukraine virtually, or it could be conversational English with kids in Japan. So, and I think when sensitive souls, like a lot of these teens, are doing service for others, it almost gives them like a break from thinking about their own problems, and they're really good at it. So it grows their confidence. So I highly recommend to any parent listening, like, if you have a kid that runs anxious and sensitive, like, that's such a little gift that they have. And having them volunteer. And if they're like, I don't want to do that, well, you can use a virtual platform like Meaningful Teens. I also do love them in person doing things. They could read books to kids in their old elementary school. There's a lot of opportunities that I think can really support these kids, and like using that sensitive vulnerability for good, rather than it like making them engage in maladaptive behaviors.
In our house, we call that using your powers for good. Same.
Exactly.
That's such excellent advice to turn that around into a positive.
Yes. Yeah. And it's like the same thing, like all these temperamental traits that a lot of these, the patients I work with have, when used for good, they're magic. When used for their behaviors, it's really scary. So like these, and I can't tell you how many patients, they want to be a nurse, they want to be a doctor, they want to be a therapist, they want to be a teacher, and amazing. Like, that's their gift. So I think as a parent, sometimes, you have to kind of push them into the pool, because sometimes they are anxious, like, oh, I don't want to do that, and you're like, I get it, and you're going to do it.
Yeah.
So and because I know it's hard, you'll get a reward for it. But if you don't do it, you don't get access to your phone or whatever you have to do. But I think sometimes as parents, you have to make your kids do things is good for their temperamental traits, even if it makes them uncomfortable.
Yes. So hard to do, but I totally agree. Wow.
I think we need, this will be cut out, but I think we need to have a panel on this whole piece that we just talked about, how it's become trendy. What can you do to help, curb that? How do we take it and still honor the fact that
100%
you may have a mental condition, but how do you also put it that in a healthy way? I think we really should.
I think we should too, because I was just talking to two friends last night, and we're all talking about the kids, and these are like adult kids in their 20s, but they still get stuck in like a victim mentality and the label of whatever it is, like anxiety, and they're just like, they just sit. It's like they're just sitting it, and they're happy to just sit in it. And you're like, no, yes, you have this, or you feel this, and now go.
Well, and I think that's where DBT is so helpful, where it's like that acceptance and change. It's like, yeah, of course you're anxious. Like you're genetically predisposed, and there's so much going on in the world, and you still need to get a job.
Yeah,
you still need to have good relationships. So like what skills, and that's where like some people need, evidence-based treatment. They need, for OCD, there's treatment called exposure response prevention. Like you need all these different treatments to be able to kind of challenge the things that are holding you back. But yeah, I think a lot of individuals, and again, it's kind of like, I always ask people, like, what's the function? Like, what are you getting out of not doing what you're supposed to do? Yeah. And usually there's a reason. Like a lot of people will say like, well, I'm scared that if I recover, I might screw up. So staying in treatment, like there's like and that's not why they have an eating disorder, but it's like a secondary function.
Yeah,
like
that makes sense.
Like the world is so scary that being in treatment's a lot. If you're so sick you can't grow up, then you're not going to mess up. So there's a lot of like components to that. And again, you kind of have to be careful to not like, and that's not why. It's just sometimes a part of the willfulness to get better.
Yeah.
Right. Yeah. Sarah, thank you so much. You have been a wealth of information, and I do hope to have you on again. I know that Emmy's going to agree.
I agree. I concur.
You concur.
Yes, of course. Yeah. Anytime you guys want me to come back. Yeah. I love supporting parents and how to effectively manage this, because it's scary. It's overwhelming. And I think you're going to see a lot of stuff about it online. You're going to talk to a lot of different people that say, do this. And I think, like I said, I think this is a nasty disorder that needs to be dealt with by experts and by in a timely way, so that your child can, successfully recover and go on to live their life. And full recovery is 100% possible.